Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, health systems, and other healthcare organizations around the nation. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this very episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. Our topic today is all about the Health Equity Index and important innovations and approaches so that you can meet your business goals and support your members the best. Our partner in crime for today's episode, our sponsor, is BeneLynk. They are a national provider of social care solutions for Medicare Advantage and managed Medicaid plans, and they serve plans and their members by creating a human-to-human connection by providing the assistance a member needs to get the benefits they deserve, enabled by cutting-edge technology. Our guests today, we have like the dynamic duo here, and I'm going to introduce them. We first have Melissa Smith. She is the founder of an organization called Newton Smith. She brings over 25 years of experience in star ratings, strategy, marketing, and sales experience for health plans, providers, pharmacy benefit managers, and other industry vendors. She was most recently the chief consulting officer at HealthMind, very well known as a healthcare strategist with proven success for developing entire enterprise-wide solutions to improve star ratings, quality performance, outcomes, and member experience. And our second person in the dynamic duo, last but certainly not least, is Keslie Crichton. She is the Chief Sales Officer at BeneLynk. She is someone who's been on the show before, who I've worked with for a number of years now. She's worked in managed care for over 25 years with a focus on SDOH solutions that have improved members' lives, but also provide a return on investment for those businesses. She's responsible for driving enterprise growth and innovative partnerships to improve the outreach strategies and health outcomes for BeneLynk's clients, members. She works closely with the product team over there to offer differentiated services and capabilities to maintain BeneLynk's position as the market leader around duals, Medicaid, Medicare engagement. So thank you both for being here, and thank you in advance for the preparation in preparing for today's episode and all the work we've done together. I think our audience is about to receive a lot of gems and knowledge and bright spots. So let's start, Melissa, with you, and let's just level set briefly. We're going to get into bright spots in a moment, folks, but I want to just provide an overview of the HEI and its impact on plans over the next 1 to 2 years.
You bet, Eric, that's such a good question. So the HEI is our Health Equity Index. Let's start with a punchline, because as everyone who knows me knows, I like to hit the punchline first, and then we'll go into a few rabbit holes around the edge. The Health Equity Index will replace the reward factor within the Medicare Advantage Star Rating programs in measurement year 2025. That's a pretty seismic change compared to the last couple of years of very tiny tweaks that we've had in Medicare Advantage Star Ratings. When this happens, we're going to have the first measurement that covers a 2-year window. Again, we're not accustomed to managing to 2-year windows within Medicare Advantage. Now let's talk about what this means for the about 1,000 plans who are chasing the $16 billion with a B dollars of quality bonus payments attached to stars. CMS has told us they expect almost 15% of Medicare Advantage contracts to lose a half a star rating in their overall star ratings. CMS expects about 2% of contracts to benefit from this change. So net, we've got about 10% of our Medicare Advantage contracts that will lose a half star rating, which will cause some, maybe many of them, to fall underneath 4 stars and lose their quality bonus payments as a result of this change. This is a pretty significant change. I will say a couple of things, if I could, about the practical impact of what this means. This Health Equity Index is a very mathematically complicated issue. A lot of you guys who know me well know that for years I've talked about the STARS math path. This health equity index has its own complicated, multi-layer, unique math path underneath our STARS math path. So we've got a lot of practical implications. Keslie's going to talk about how to find the right folks to help get benefits for good care under the Health Equity Index. And Eric, I'm excited to see where our conversation takes us in the next couple minutes.
So I just want to summarize it. So obviously, this is not a tiny tweak. It's a big change in the reward factors in stars. Starts in 2025, but the measurement, which is not usually is not a normal change, is for 2 years versus 1 year. So that's going to be something that's a little bit, if the organization's already prepared for that, a little bit of a shock. And CMS is forecasting that 15% of the plans out there are going to lose a half a star. Only 2% are going to benefit.
That's exactly right. Exactly right. So a lot of financial impact, operating impact, analytics impact, prioritization, strategies, tactics. This touches almost everything that a Medicare Advantage plan does and invests in order to be successful.
So let's then jump right into it. Let's leave our listeners in suspense. How would you go about, if you were at a plan, of creating a strategy and a process to avoid losing the revenue associated with stars? Let's not be in that 15%, Melissa. So maybe take me through a real example if you could think of one.
Yeah, so let's talk about real. As you said, Eric, this is a bright spot. So let's find the bright spot. So if I'm a plan and I want to avoid losing my star rating, we've got to start with our reality. We need to begin with our stars dashboard, our stars analytics, and quite simply add the health equity index. What that means is we need to add fields and elements and calculations at the measure level, at the provider level, and at the member level to make sure we're achieving the math necessary to earn the health equity index. Now we've got some samples. We can share some samples with our listeners after the fact. It shouldn't be a secret. The math is the math. And there are some really great tools out there to show the art of the practical in chasing this math of the health equity index.
Okay, so we need to add to the stars dashboard and an HEI, and we need to add fields and clarifications tied to the measurement, the provider, and the member, those levels. Now, if you want to tease us with a tool or an example, I'm happy to include that as a link somewhere in the description of the show, as people are kind of looking at their podcast app right now. Do you want me to
Would love to. Yep, happy to. Happy to. We've shared that for years. You know, a lot of our listeners know that in the mid 2010s, when we first learned about the reward factor, we did the same thing. We put samples out free of charge. CMS puts them out free of charge. We just promulgate sharing the analytics. We've done that in the mid 2010s. We've done that with the improvement measures. Happy to do that around the health equity index, so your listeners have some good samples.
Awesome. All right, so we'll include that. As you're listening right now, there's going to be a link in that description. You should be able to click on your finger, or if you're watching it, listening to this on your computer, you'll be able to click on it. We'll also get on the YouTube description. Thanks for that, Melissa. Let's bring in Keslie and talk about Keslie, how are you thinking about which members to target, and how do you get members covered as a dual or even LIS, depending on what your target is, so that you can maximize the revenue potential here?
Yeah. It depends on what state you're in, right? It's a little complicated. And the old saying, if you've seen one Medicaid plan or one Medicaid state, you've only seen one, and it literally is different in every state. I think the ultimate starting place has to be a predictive model. And first, you have to measure what you have, right? So how many members do I already have that were disabled as their pathway to Medicare, that are already dual enrolled and that have LIS? Then you have to take your remaining population and say, according to MacPac, and they update this fairly regularly, about 50% of those eligible for dual or an LIS are not currently enrolled. So if you have that population that's not enrolled and you look at that and you put some predictive algorithms on it, some modeling, right? You want to look at things like the census data is easy, right? What zip code are they in? but you want to go deeper than that and wider. You want to understand what those members look like from a gender perspective, the marital status, age. Some of it can be kind of common sense, right? I gave you the example before, a female over the age of 75 that's single in the Bronx is probably, it's pretty much common sense. She's going to be more low income than a married couple under the age of 75 in Greenwich, Connecticut. So some of it's that easy to kind of start with, but then you have to look at what age brackets are we really looking at, and then apply some living modeling to it, right? Not only do we think that they're eligible, but what's the likelihood that they're going to respond to outreach from the health plan or a vendor, either one? And then what's the best mode of communication to get somebody to respond, maybe by gender, maybe by age, maybe by region? And then make sure what you're doing is actually coming through. If you called me today and said, how would you like to be communicated with? And I don't really want to talk to you, I'm going to tell you a text message because it's the easiest to ignore you. So now if you're going to text these members, you need to also say, did they follow through? Did they opt in? Did they call us? Was it really effective? Or do we need to look at that population differently and communicate with them differently?
I mean, there was a bunch there. I want to summarize it.
Yeah.
So roughly 50% of those eligible for both Medicaid and Medicare are not enrolled in Medicaid. You need, as an organization, to be both pragmatic and a little bit sophisticated in creating some predictive models on who to target to get those folks enrolled: gender, age, marital status, zip code were a few examples that you just brought up. But then you want to get more specific from that subset and include who's likely to be eligible, but also respond, likelihood to respond. So that gets a little bit more detailed in the sophistication required. And then when you get that subset, you need to understand the best way to communicate. And you mentioned two things. I want to make sure: one, the modality. So, kind of marketing 360, omni-channel stuff. So text, phone call, email, whatever, but then also the words you choose to communicate with different individuals, the words that are going to resonate, probably the language even too, correct?
Yeah. Yeah. We found out working with a health plan in New York years ago, right, that when we were looking at kind of analysis of all of their different preferred languages, that we had a population of the Chinese that no matter what we did, they weren't responding to us. They weren't responding to phone calls. They weren't returning calls. They weren't opening up, or if they were opening their mail, even in Chinese, they weren't calling us. And we did a game changer. We put Chinese speaking, Chinese looking people in Chinatown, and the outreach was off the chart, right? It had to be in person to have that trust and validity to get that population to follow through.
Interesting stuff. And I'm sure even though it was face to face, probably returned a pretty good ROI for the health plan.
Yeah, absolutely.
What, so I mentioned sort of an outline. I did mention some tactics, at least around the algorithm itself and thinking about the omni-channel marketing. But what other components or tactics do health plans need to be thinking about?
I think you need to, you said it, and I'm trying to remember what word you used, but it needs to be local, right? And local sometimes might mean by city, by county, by state, by region, but you want commonality wherever you can. And you want to use the same language that state Medicaid agency is using or Social Security Administration is using for SSA, right? You want to use consistent messaging across the board. So if you're in Wisconsin and it's Badger Care versus you're in California and it's, Medi-Cal, use names that people are familiar with. If you can find other commonality, right? So that if you are calling these members and you can be calling by region, and I'm in New York and they're in New York, and say, gosh, the weather is just really bad today. How are you doing? Are you snowed in, or whatever the circumstances might be? Try to catch that commonality first of all, and build that which is going to build your trust and your validity to kind of continue on with that conversation. But also then kind of, introduce yourself, but show some empathy and become an active listener and start listening to what that member is saying their challenges are.
So I want to ask a follow up. So our strategy in the corner office is we need to increase our dual membership. Okay, so that's the strategy. We've just gone through a bunch of tactics to do that, but I think there's something missing in the middle on sort of like what infrastructure or components need to be brought in or built for a health plan to be able to do this really well? Because you mentioned a lot of things, not only the predictive modeling earlier, but even tactics to be local, understanding the same language that the state Medicaid agency uses. So there's a lot of things going on here. If we were sort of in the corner office together and we're having a board meeting, what would be some of the things that you would advise a health plan must have in place, whether it be in-house or outsourced, to be able to effectively deliver on these tactics and thus deliver on the strategy?
I mean, ultimately, what you need is an eligibility engine, right? That really understands every pathway to Medicaid in that particular state. Massachusetts, 6 different applications for different ways into Medicaid versus New York is just it's MSP or ABD, right? So you need to understand the pathways, the programs in that state, and then all the nuance that comes underneath that. Some states will have an ineligible spouse has different criteria than if both spouses are eligible for Medicare. So really diving in and being an expert on your state or states, and sometimes this is at a county level, on what's going on in your market so that you know how to effectively help all the members in that market and at the highest level, right? It never used to matter. So before 2017, before the risk adjustment model change in 2017, health plans and vendors, for the most part, right, only wanted to get somebody enrolled in Medicare savings programs. Why? Because it was one application and the revenue to the health plan was the same no matter what. A dual was a dual. There was no, while we still had full and partial, the revenue didn't change no matter whether the member was full or partial. 2017, we borrowed from Peter, the partial member, right? And we gave it all to the full member. So your average Medicaid add-on for a partial might be $25. It could be $250 or more for a full. And so now you have to make sure that you or your vendor understands the differences between Quimby, Slimby, QI1, all the alphabet soup of a Medicare savings program, or getting somebody enrolled in ABD, Medicaid, full Medicaid. And in some states, make it even more complicated. That means you have to start with an SSI application to Social Security Administration before you can even get that full Medicaid from the state Medicaid agency. So
Okay.
I guess what I'm saying is it's complicated.
It's complicated, and you have to have some deep individual, if you're multi-states, deep knowledge of each state. I'm going to come back to you and talk strategy even more in a moment around the HEI strategy in general, but I want to quickly move back to Melissa for a second. And let's imagine now, Melissa, through Keslie's guidance and leadership, we've been able to bring in a lot more members, right? BeneLynk's delivered, and now the health plan has increased their dual membership by 50, 60%, maybe even selling them short. And what do we do now, Melissa, once we have the member?
That is such a good question. And I have to say, of all the questions we've tackled in the last 6 months, that has been the question that's the hardest to answer. So let's start with the reality of which members meet the criteria to be measured under the HEI. The member has to have dual eligibility status or be eligible for low-income subsidy for your Part D drug coverage, or have earned their Medicare eligibility based on their disability status. So by definition, we're talking about people who are not wealthy. They are not well. They're not striving to be as healthy as possible. They're generally trying to survive day to day, week to week, month to month, and get the basic care they need. Poverty level right now is $15,000. Almost 100% of our duals have an annual income under $20,000. So when we first get these members, Eric, what we have to do is make sure our organization understands the member. Do our care managers, our customer service folks, do our vendors, do all of the parties that service this member understand how to interact and help people who are poor, people who are struggling, or people who are literally disabled as the reason they're under 65 and on Medicare and had to fight 2 years to get that. Now, I point that out because there's a lot of organizations who are in MA because it was a money game. For years and years, this Medicare Advantage has been a money game. We have a lot of plans that got in, a lot of our clients, in fact, over the last years, got into Medicare to serve healthy, wealthy, white, independent members that have great households and great support structures. And this Health Equity Index actually rewards us to the degree we serve the lost, to the degree we support the strugglers, not the ones who are healthy, wealthy, white, and well-educated with a lot of support. So, so what do we do? What do we do is a complicated question to answer without first answering, what is our corporate mission and vision? If you happen to be an MA plan, and we work with plenty of them that just wants to pay claims, pay benefits, and work the actuarial float, probably just need to not worry about earning the HEI. If you don't want to empathetically work with people who are strugglers, give up and move on. Tackle another pathway to your star ratings without the HEI. But if you do want to get into the space of really knowing and supporting your duals, your LIS eligible, and your disabled members, this is where the concept of upskilling, reskilling, re-educating is vital. We've done a lot of work in this space in the early days of Medicare Advantage Stars that sort of fell by the wayside pre-COVID. This probably means bringing back staff training. It means bringing back we did some training while I was in the plan space where we used books like the $2 a day, Living on $2 a Day, to teach high-end professionals the real world in impoverished communities that lack resources. Probably means we've got to bring some of that back. It means we need to reteach staff what it's like if you can't see well, can't hear well, if you're on disability because you've got unreversible, irreversible mental and brain disorders. There's a lot of just training and support we've got to build that we lost during the COVID years.
Yeah.
The other thing, let me offer one other thing, and then I know you've got a couple questions, Eric. The other thing I want to point out that we've run across with every client we've worked with in the last year, every member who's a dual or has low income subsidy for their drug cost coverage or is disabled needs to have a primary point of contact. Perhaps if you're running a D-SNP plan, it's your care manager and your interdisciplinary care team, your ICT. Perhaps it's somebody who's your caregiver, a true caregiver of record. Perhaps it's a provider that you've attributed the member to. Plans need to know who that primary point of contact is for each of these people, and then where they put the layer of wraparound care and support for success. Not easy.
CHWs in that mix too?
CHWs, good question. So CHWs are community health workers. We are definitely seeing an upsurgence/resurgence of CHWs that are really high value. To date, they've been a little bit underutilized. It's been more of a directional, loosely connected activity, but definitely seeing a lot more vendors and personnel getting out into the field post-COVID, which is a great way to support these high need members. As Keslie said, Keslie and BeneLynk are fantastic at doing the first part of the moral imperative, which is connect the poor people and medically disabled people with the resources that they're legally entitled to. That has got to be step one. Then we can do step two and a million permutations. And again, this is the conversation in the corner office to your question, Eric. Every executive team has got to come up with an identity they're willing to live with, align with, invest in, and activate once Keslie and the BeneLynk team can get them connected with the benefits they're entitled to.
I want to follow up with two different interesting things you said for real quick, because there's two things that you said that I want to make sure we double down on. And one of them will lead into a question I have for Keslie. So the first is, you mentioned the concept of just giving up on the HEI index, like let's just punt on it. And so I wonder if you could go into that a little bit more, because, in principle, from an altruistic standpoint, it feels pretty callous, but from a business standpoint, there could be an argument, trying to do better for everyone that we care for, that if we pour too many resources into someone where we're ultimately going to fail, we're going to hurt the rest of our membership. So is there like a basic sort of revelation that you've had with clients around when health plan A should just punt on HEI and health plan B should go all in on HEI?
Absolutely. Remember what I started when we began this. The Health Equity Index is a mathematically complicated multi-layer formula that we can't do justice to sitting here on a podcast. But you can't even earn an HEI unless you have a percentage of your membership that is at least 50% of the national median across all plans. So sort of a gating threshold, if you will, that if you have less than 50% of the median, you're never even going to earn the HEI. It's not even a possibility for you. So the first step for plans is to say, what is my current percentage of duals, LIS, and disabled members? Not currently disabled functionally, but disability is the original qualification eligibility for their Medicare coverage. If you're really far off from the 50%, it probably doesn't make a ton of sense to worry much about the HEI unless, to Keslie's point, unless you've been serving a largely under-resourced group of people who are actually eligible for LIS or dual status, and they aren't connected with that legal entitlement, and they need somebody like Keslie to help get them connected and flow them into the HEI. But this is the first conversation among a boardroom of are we close? Are we guaranteed? Are we a maybe? How close are we? How close are we to losing it? And then this is a complicated business calculus if you do this just to chase the QBPs.
I imagine if you're in a market, let's say you're in a market with 2 or 3 major competitors, let's say I'm a regional plan, I got another regional player and a national player. If my guess is because HEI is new and pretty hard to do, if I double down and go for it, let's say I have I'm right around the Mason-Dixon line as far as my percentage of members. But if I double down and do it, and let's say I hire a BeneLynk to help me or whatever, and I go put my chips all in the middle, maybe one of those health plans may just punt on it. And the other, if they don't put all their chips in, they kind of go at it sort of half-baked, not all in, but half in. There's a massive opportunity for me to pick away at that market and dominate that market. So there's probably some component of the market strategy that would go into that decision.
That's exactly right. Well, and a lot of folks don't realize that I'm actually a finance person by background, not a clinician. Let me put on my finance hat for a hot second. This is going to be the true test of how we approach our work in star ratings. There are plenty of plans that are very tactical, chasing measure lists, chasing gap lists, letting the star's tail wag the dog a little bit. But for the plans who do their stars work right, and the right way, aligned with a triple aim, when we do this work right and well, we actually disrupt the medical expense trajectory and we drive financial savings through our success. So again, this is a little bit of a hard visual to pop out on a podcast, but the business trajectory for the plans that are all in can't be just teaching to the test measure by measure. If we do this work right and morally and strategically, we'll reduce medical spend while we chase health equity index. And there's a plethora of evidence-based literature that supports that. It's the entire basis of the triple aim and why every measure's in stars to begin with.
Okay.
I think if you go, but hey, well, let me just pile on to her for 1 second, Eric, because I think what she said was really important is where CMS wants us to go is do the right thing for this member first. Don't worry about the health equity index, whether you're going to get it or not, right? And you don't have to have a DSNP to have low income members in your population. And there's other reasons to help people become duly enrolled and enrolled in LIS. There was just a study released by JAMA that I think Health Payer Intelligence or something pushed out last week, where it shows that if you help somebody become enrolled in LIS and they lose that benefit, they stop refilling their prescriptions because they can't afford it. That's another one of your medication adherence measures, right? There's so much more than just chasing the HEI that's important here. And you've said the word twice. Morally, if you're trying to deliver the best care for your member, this is something you should be doing for them.
I'm looking at a JAMA Health Forum study published on February 2nd, 2024, the associations between annual Medicare Part D, low income subsidy loss, and prescription drug spending and use. Is that?
Yeah. Yes.
Is that production on the fly? And that's what you get here at Bright Spots. Okay, I will. I will take this link and make sure that we get it into the description as well. So I want to come back. I want to tee you up here, Keslie, and come back to something that Melissa said around empathy. So I've been doing the show for over 10 years now, and some of my favorite moments on the show, and there's not a lot of these moments that just totally stick out to me, but I've had a couple of health plan guests over the years talk about their investment in empathy as a strategy, truly not just talking about empathy, but investing in it. And I remember one health plan in particular who actually have their executives take rounds in the customer service department, taking calls from members, so that as Melissa outlined, they could hear, members, maybe they're not going onto the streets or living for $2 on a day, but they're literally talking to folks who are hard of hearing, talking to folks or a caregiver who's with someone who's mentally disabled for some reason through an accident or some other natural childbirth, all the different hardships they're living through, and really understanding what it's like more to be them or be part of their family, so that empathy as a culture kind of seeps into the organization. That's so important and so admirable, I think, to as a healthcare organization. We talk about it a lot, but we really don't deliver on it. And so with that as an overlay, I'm wondering, if we could talk a little bit about how do we, like, what are the components that a health plan needs to be thinking about? What's the strategy they need to be thinking about for HEI in general, and how to incorporate everything what we've talked about today so far into making their HEI scores successful, and their overall approach to duals and LIS more successful? I imagine empathy as a strategy or empathetic listening has to be one, but what are some other things?
Yeah, going back to the HEI, let me ask Melissa kind of a tag along question with that. If you were running the health plan and the HEI is at a contract level, right? Not at a plan level, would you be looking first at your contracts that have the best HEDIS scores, and then looking at your health equity index and saying, we're 5 stars in this contract number, but we're a little shy of our dual LIS penetration, right? Let's focus on that.
That's a good question, Keslie. And Eric, your question is different but similar. So what I would start with is a reminder that the member doesn't have to be either. Hold on. Let me gobble those words back up. You can see the mathematics are complicated, and even those of us who know the math still get complicated and tongue-tied. The way the health equity index is computed is by combining all of your duals, LIS, and disabled into one bucket. And then you look across every single measure. Largely, it's going to be HEDIS, PDE, CAPS, and HOS. Now, if we think about these members, we're going to have to think about the fact that these are the members that are usually problematic, not always in HEDIS, but around medication adherence, CAPS, and HOS. So Keslie, I guess my way to answer that is I would start at the contract level, and I would look at every possible data element that's conveniently available across that measure set. Every plan's got a little different mixture of which measures they've got good data for, which ones they're flying blind on. So my first answer is I wouldn't try to overscript the analysis. I would just sit down with a STAR leader or a MedEcon leader and figure out what do we have that we could look at to do the best we can do without re-engineering the wheel. But it will go past HEDIS, for the folks that are still kind of trapped in HEDIS and glad CAPS is going back to double weights. This is going to be all the member facing measures that our friends and neighbors in need to focus on. It's a complicated, I think if we're uncovering anything, Eric, before I answer your question, I think if we're uncovering anything, it's the reality. There's not any one single answer here. There's a lot of deep thinking, deep work to be done to figure out what you want to do as a payer. Okay, Eric, can I flip back and use that to piggyback an example onto your question? So your question is really, let's say BeneLynk gets in, we get them qualified for their dual status, their LIS status, disability, not so much, but they've got this new Medicaid coverage, for example. Then what do we do? This is kind of where a plan who wants to chase the health equity index does the right thing by getting dual eligible members their Medicaid coverage. Now the rubber meets the road for empathy because Medicaid is complicated. We've got to retrain customer service reps. We've got to retrain care managers. We've got to retrain vendors on how to make sure we're helping the member navigate what we offer in MA and what they now have access to in Medicaid. Can the member read? Can the member understand? Does the member have a caregiver they rely on? The complication factors are immense, and it's embarrassing. I mean, let's kind of go back to empathy as a strategy. Dual eligibility means a person is impoverished, not going to come back out of dual status, likely if they're Medicare eligible. A lot of people that are dual eligible are embarrassed about their need for the coverage and their need for the assistance to get the coverage. So again, we've got some learning and growing. My best advice for payers right now isn't to try to overscript this year. It's to embrace change management and go step by step through what they're willing to do and what's within their corporate identity, because this is sensitive subjects. This is not just, financially lucrative behavior patterns. This is, what are we going to do next with people who are in need in the privacy of their own homes?
Really
You
good.
hit something really important with just kind of going back to that empathy, right? Like, let's not tell somebody right off the shoot, right? We'll get there, but let's not say we think you're eligible for Medicaid. We think you're eligible for Badger Care. Sounds better if you live in Wisconsin, right? We think you're eligible for the low income subsidy, or we think you're eligible for extra help. Extra help sounds better. You're talking about a proud population that maybe lived through World War II, right? They don't want a handout. They came to this country to make it. And the fact that they maybe never made much money to begin with, or they've spent down their assets due to income or sickness or whatever, right? You don't want to kind of make them feel poor. And so I think it's really important, and again, towards the Health Equity Index, that LIS, extra help, is such a neat benefit. We saw from the article that we talked about a few minutes ago, right? It improves retention, it improves medication adherence, it improves member satisfaction, all of these things. But it also casts a wider net at 150% of federal poverty level instead of 100 for full Medicaid, right? So more people are willing to raise their hand to say, yeah, I make $1,900 a month, even though more people do, right? Then I make $1,000 a month. And so just how you phrase that, how you present benefits to them in an empathetic way, but also using the right terminology is going to make a difference.
I'm gonna summarize high level, just so this is what I've heard so far as just the overall strategy. If you're listening to this, you represent a health plan. Here are the key components that I've collected in my note taking right now, that our two guests have outlined for everyone. The first is empathy as a strategy, and that includes training your organization on empathetic listening and truly coming up with programs within your organization to drive home what it's like to be a dual member and feel it, and in some cases, if possible, live it, so that you could best serve those members. The second is not entirely independent, is to be able to speak local, right? Whatever that's the language, the native language, or just even the jargon of that neighborhood or that town, customized scripting. The third is making sure that you choose the communication most effective for that population, and you test it. And if you make a mistake, fail fast, and try to change the communication channel, like that example you gave earlier in Chinatown, where nothing was working. We went feet to the street in Chinatown, and that was the big moment there. That was Keslie's, I think, story. And the fourth is having a deep expertise in both your state and maybe even your local municipality pathway to Medicaid eligibility, which requires a bunch of expertise. So I'm going to leave it with those four things, and I don't want to get too commercial here, Keslie, but I do want to ask a question because I think it's important to put a bow a bit on this. Is, if a health plan is going about this on their own and can pull this off on their own, great. But I think in more cases than not, they're going to want to be looking at a partner or partners to do that. And I know your bias, But with that in mind, what would be, if you were at a health plan, some of the key characteristics and capabilities you would look at in a partner to be able to do this for you if you were at the health plan? You know, how do we select the best vendor to accomplish this effectively?
Yeah. Besides the points that you just made, I think the details around each one of those points, right? Is the vendor flexible? Meaning, I have one client that does some work with an ACO that they own, right? So some of that communication they want to come from that ACO's brand, other from the health plan brand. Is the vendor flexible? Are they willing to take their advocates to the street? Do you have your own kind of regional street offices for your plan? Do you have vendors willing to do that? Can they customize data so that the letter that vendor is sending out resonates and looks and sounds like your same communications that your health plan is sending out? Empathy, we've kind of hit that in every form, but really, you talked about making the person that's making those calls really understand what it's like. And there's physical things you can do to kind of bring that point home. Put marbles in your shoes and walk back and forth a couple of times across the room, and you will remember to ask that member for everything they need to collect so they don't have to get up and down 5 times, right? So there's things like that. The Medicaid expertise, it needs to be deep, but also the relationships that vendor has with states as well as with CMS. And then lastly, I think going back to the top of that, is their predictive model accurate? Is it living and breathing and adjusting to your population and your market? And so I think when you roll all of those together, I think that's really the criteria and what sets us apart from our competitors.
I'm going to try to summarize that. I might have missed some, so help me out, especially at the end, because I was typing vehemently. I might have not cut every word you just said towards the end. So here we go. Vendor flexibility. Okay, can they flex to what the health plan wants, especially the products that they have, and most importantly, where they want to be communicating? Can they move their advocates on behalf of the health plan, let's say, to the street, like you did for the Chinatown example? Secondly, can they customize the data so it fits within, not only the data, the communication that comes out from the vendor? Can they customize it so it fits within the plan's brand and the plan's cadence, is what you mentioned.
Yeah.
Fourth, and not in any order of priority, is this a vendor that already practices empathy and already has empathy as part of their culture? Are they a culturally empathetic organization to begin with? Fifth, do they have deep Medicaid expertise, and do they have relationships with the states and the municipalities, so when things change or get adjusted or you need to figure something out, that it could be easily done? Could a vendor do that at a national level? Are they strong in those states and those municipalities? And the last one, the sixth one, I missed.
It was just about the predictive model, right?
Oh, the predictive model. That's right.
Everybody's so afraid of member abrasion, right? You don't want to send a letter or make a phone call to all of your members, especially if you're that well-to-do health plan up in the Midwest that was the example earlier, right? You're more likely to insult that membership than find a dual, if that's what you do. So you have to have a good model that's really going to run accurately at predicting who's likely to be dual eligible for LIS and become enrolled.
Gotcha. All right. I know we're running a little bit long here. Melissa, we're going to ask, where can people find you? Well, let's start. How you've said, how, if people wanted to reach out, connect with Melissa Smith, how do they do that?
I think I'm just about the easiest person in America to find, even though my last name is Smith. Hop on LinkedIn, Melissa Newton Smith. I do a ton of educating and all informative posting out on LinkedIn. I try to do my very best to share knowledge and information. So LinkedIn is my anchor, Melissa Newton Smith. I'm very easy to find.
Awesome. And I always like asking, if we have time, Melissa, in the spirit of, and we talked about this before we started recording, anything that outside the industry or even inside the industry, I'll let you go inside if you want, that you've read recently, that you've watched recently, that you have found particular inspiration in as you think about what you do every day and who you're doing it for, that maybe you could recommend to our audience as a big little extra takeaway?
Yep, you bet. So with the first caveat that I'm a really big reader, I'm literally a voracious reader. I'm actually sitting on 2 books sitting on the corner of my desk that have impacted me enough in the last 90 days that I have not even moved them away from my right hand. I'll tell you what they both are and why. The first one is Because I Said I Would. Bears no resemblance to anything in the healthcare industry. Written by a motivational speaker that I had the pleasure of following to do a keynote this last fall at Prime Therapeutics Stars and Bid Summit. It's all about committing to things that we're willing to say we're going to do and then do them. Great for those of us in Medicare Advantage. If all we want to do is make a profit, pay claims, offer benefits and services, let's do that. If we are going to say we care about the member, we're going to serve the member, going to support the member, time for us to live by the Because I Said I Would principle. And I'm happy to share a link to that as well. Second one inside the industry that I would share that we've touched on a couple of times today, we've talked a little bit about ethics and morality. Sadly, our time together is so short that I haven't even begun to be able to talk about the ethical conundrum around risk adjustment for duals and how this focuses with Medicare-Medicaid alignment. But my friend Ellen Fink-Samnick has written a book called The Ethical Case Manager, Tools and Tactics. It focuses on bringing the ethical conversation to the business of case management. I've told Ellen, and I'll write a blog about it that we can post later after this session. I've told Ellen our next assignment in Medicare Advantage Star Ratings through the Health Equity Index is to apply her principles of ethical case management to our STARS work plan strategies and investments. We're going to have to think about what we do deeper, broader, et cetera. And we're going to have to challenge our ethical decision-making as we approach our chase for HEI.
Great stuff. More links for everyone. Keslie, why don't we, any recommendations that you may have, and also where can people find you besides coming to me, which of course they can. So all your details to anyone that wants to, but where could they find you to?
I'm pretty easy to find too. I think if you just type in Keslie in the Google search, you can find my cell phone number, my email address, and everything else. So, but it's Keslie.Crichton@BeneLynk.com, Keslie Crichton on LinkedIn and Facebook and any other place. So I'm going to skip the recommendations on the books. I don't know if I've finished an entire book in months. Big podcaster. I'm all about like putting the health back into healthcare, focusing on good nutrition and exercise. And I want to go kind of skidding into the last 20, 30 years of my life in a healthy body. And so thinking about that right now more than, really sick care. So trying to eat well and get some exercise.
I know we got to go. I will tell you, as someone that is wants to up their game as a podcast host and a leader in this space, I purchased and read A Curious Mind by Brian Grazer and followed up with this book Face to Face because the first one was so good. And the reason I bring it up on this show is not because necessarily I know you guys don't want to become podcast hosts, but it's all about listening, asking questions, and connecting with people. So when you're thinking about empathy as a strategy, if you're an executive at a health plan, I encourage you to read both those books. They're really good reads. Brian Grazer, no relationship to Glazer, Curious Mind and Face to Face. Thank you both.
Thank you.
Thank you.
A really incredible job today. I hope all of you listening, you take some of the ideas shared on today's episode of The Bright Spots to change your thinking and enhance your company's current approach to improving healthcare for all of us. We produce this show for you. This is your Bright Spots in Healthcare podcast.